Okay. The following plants are all sources of anti-tumor agents except Ipoma batatas, Taxus brevifolia, Cinchona succirubra, and Podophyllum putatum. What do you guys think? I think Taxus brevifolia, as we discussed earlier, that it is used for breast and ovarian cancer. Can somebody tell us the uses of others? I feel that is the answer. I am not sure, but I feel it is the answer. Oh, sorry. All the following are sources of, oh no, except. Yeah, so this one maybe. It is Ipapomium is a sweet potato which is used for anti-diabetic and inflammatory. I don't know what the answer is. So let's discuss. Okay, it does have an anti-cancer activity, so I'm not sure. We will go for C. Anybody wants to add on anything? What is meant by a lead compound in medicinal chemistry? A drug containing the element lead, a leading drug in a particular area of medicine. a compound that acts as a starting point for drug design and development, a drug which is normally first described for a particular disease. I think it's C. I don't know what the others think. Mhm. I think we're discussing the questions also, not just answering. So anybody wants to add on a point or anything? Which part of the acetylcholine molecule interacts with the binding site of cholinergic receptors by hydrogen bonding? The acyl methyl group, the esteric group, the quaternary nitrogen group, all the three and methyl groups. Which part of the acetylcholine molecule interacts with the binding site of cholinergic receptors by hydrogen bonding? The acyl methyl group, the esteric group, the quaternary nitrogen group, or all three N methyl groups. You could explain why A? Do others also think it's the ester bond because of the oxygen atoms? I don't think this is a discussion, so I'll just continue. Maybe does anybody want to add on anything?
I think it's the acyl methyl group.
But I feel that's an ionic.
It's the acyl methyl group.
Okay, what according to the internet, it's saying that the acyl methyl group will bind using ionic bonding, not hydrogen bonding. Yeah, and esters because the oxygen atom serves as a hydrogen bond acceptor. Anybody with a different answer? What is the crucial feature for activity in tuberculin molecule isoquinoline ring, phenol ring, aromatic ring, two positively charged nitrogen atom?
Who could say is isoquinoline ring?
Choice D.
Lol. According to ChatGPT, it's saying D because it's the nitrogen, positively charged nitrogen atoms are essential for its neuromuscular blocking activity.
Hello. I would like to the choice is D because the tuberculin is an antagonist at nicotinic receptor. So it has to have features which resembles that of acetylcholine for receptor recognition. So the answer is two positively charged nitrogen atoms, which resembles that for the acetylcholine has a nitrogen atom. So it will be recognized by the nicotinic receptor. Yes, so the choice is D.
Thank you, doctor. So we'll go for D. Okay, we can talk a bit more on this thing. Okay, you've already given us a bit. Can somebody explain the what do you say, mechanism of action?
Maybe not mechanism of action, but so tuberculin is a neuromuscular blocker. So there's two types of neuromuscular blockers: the depolarizing neuromuscular blockers and also the non-depolarizing. So tuberculin is a example of non-depolarizing together with vacuronium and rocuronium. And then for depolarizing, the examples include succinylcholine.
Maybe to add on what Dr. has said is on when you look at the non-depolarizing, also called competitive. The non-depolarizing, also the competitive, means they will be antagonists. What they will do, they will block the activity of the acetylcholine at the nicotinic receptors. So that's why they will be non-depolarizing. But for depolarizing, such as succinylcholine and the others, what they will do, they will act like an agonist, and there will be an action potential, but it will be so persistent to a situation whereby now it will no longer cause an impasse, because it will be so excessive, like every time stimulation to a position whereby it will cause paralysis instead of causing an action. So that's why they will be depolarizing. So competitive and non-depolarizing, and depolarizing and non-competitive. Thank you.
To add on, the examples of non-competitive will be succinylcholine. And yeah, we also have the spasmolytics as skeletal muscle relaxants. Maybe somebody can talk about it as well. I don't think we can finish discussing the whole paper or even barely 10 questions if we move at this rate. So please let's start engaging and talking. If not, at least put in the chat box something.
Maybe what I can ask, remember about the spasmolytics, they are just muscle relaxants in a way. And what they will do, most of them will interfere with calcium release at the causing at the sacroplasmic reticulum, meaning the muscle won't have contraction, but it will depend on their position of activity or the site of action. For example, if you talk of something like dantrolene, for it will act centrally. But for things like benzodiazepines,
I think the dantrolene is directly acting, not
okay,
central.
oh, okay, sure. Baclofen acts centrally
Yes.
and by potentiating GABA, but dantrolene will act by interfering in calcium entry, but so also benzodiazepine can also act via the mechanism we saw the other time of potentiation of GABA, leading to muscle relaxation. Thank you so much.
Thank you. And also to add on, between the neuromuscular blockers, they'll relax the normal muscles, but spasmolytics reduces spasticity, and neuroblockers will interfere with the transmission at the motor end plate, while spasmolytics is, as she mentioned, that it's centrally acting, and neuromuscular, there's no CNS activity, and it's used primarily as a general anesthesia, while spasmolytics is used in a variety of neurological conditions. Yeah, I think that's what I have. Should we move on to the next question? Or we can do the classification of non-depolarizing based on duration of action. So in the ultra short, we have the rapacuronium. In the short acting, we have mebacurium. Intermediate, we have atracurium, and the long one, you have the doxacurium. Anybody wants to add on anything? Which one of the following is a water-soluble amino acid analog, anti-seizure drug, lamotrigine, gabapentin, felbamate, or phenytoin?
Gabapentin.
Gabapentin. Why not phenytoin?
Google says
I was thinking-
gabapentin. Also, the other drug, I think it's called levofloxacin something. It's also a water-soluble amino acid analog.
Anybody else wants to talk on that? Okay, since we're talking about anti-seizure, we can talk about the different. We can start with seizures, or somebody can talk about it, and then the different types of seizures. Maybe a bit of pathophysiology, then treatment. Okay, so seizure is just a behavior that is caused by disordered or synchronous and rhythmic firing of the population of neurons. And epilepsy is the disorder of the brain that can be like periodic and unpredictable occurrences of seizures. So they are classified either as partial seizures or generalized. So in partial, you have that means they are it's local, yeah, and the activity starts in only one part of the brain. So you can have either simple or complex or secondary generalized seizures. In that, simple is just the activity with when the person is yet alert, while the complex one is the activity with the change of awareness of the surrounding, and the secondary one is begins in one area and then spreads to the rest. So in generalized seizures, we say that it's bilaterally symmetrical without the local onset. So it can be absence seizure, which means that staring and blinking without falling. Myoclonic, that's just the jerking movement of the body. Then you have tonic clonic, that's the stiffening, falling and jerking of the body. Then you also have tonic and atonic when you fall on the ground. It can be caused by drugs or even genetic drugs like theophylline. Yeah, I have that. Head trauma, CNS infections, tumors, or strokes. I don't know about the pathophysiology. Maybe somebody can explain the pathophysiology.
Maybe it's simple. So for seizures, there's the what is it called? The excitatory neurotransmitter is more active than and then we have less inhibitory neurotransmitters. So there is excessive electoral disturbance, imbalance between the two neurotransmitters. So it also says nearly all seizures stop spontaneously, like they stop spontaneously on their own because the brain inhibitory mechanisms overcome the abnormal excitation.
Thank you. Okay, for treatment, we have the anticonvulsant drugs that work depending on various mechanisms. So you can have the sodium channel blockers such as phenytoin, carbamazepine, lamotrigine, and then you can also enhance the slow inactivation of sodium channel using lacosamide. You have the GABA receptor enhancers like phenobarbital and benzodiazepines. Then we have the NMDA blockers like palbamate. Then also the T calcium channel blockers like ethosuximide and valproate. Then we also have the L calcium channel blockers like lamotrigine. And carbonic anhydrase inhibitors like topiramate. But now the drug of choice definitely depends on the specific seizure disorder. So for like the first line for partial seizures will be carbamazepine, phenytoin, or lamotrigine, and then for generalized seizures, like if it's absence or myoclonic or tonic-clonic, either of them you can remember that valproic acid is like the first one. So valproic acid can be the first line of drug for any type of seizures. But if it's absence, it's recommended that you give ethosuximide. And for myoclonic, clonazepam, and tonic-clonic, carbamazepine. Maybe to remind ourselves of the major side effects for like example, phenytoin, the patient may have megaloblastic anemia, gingival hyperplasia, or hirsutism. And if there's a hypersensitive reaction with phenytoin, the patient may develop SLE. Anybody wants to add on anything?
Maybe the triggers, seizure triggers other than the drugs you have mentioned. There's pregnancy, there's puberty, there's hormonal changes occurring during the time of menses, there's sensory stimulation, there's sleep deprivation, and physical and emotional stress.
Thank you. So for this one, we go with GABA, that is water soluble, or anybody having a different answer? Again, just to remind ourselves that lamotrigine is a block of the repetitive actions of sodium channel, and also N or L calcium channel blocker, whatever you say. Then gabapentin, the H current modulators. Valproate is the NMDA receptor blocker, and phenytoin is a calcium blocker. Anybody wants to add on anything? All the following are selective norepinephrine reuptake inhibitors except nortriptyline, atomoxetine, mapentrin, or amitriptyline. The amitriptyline SNRI except, isn't nortriptyline and amitriptyline TSCA? think the only SNRI here is atomoxetine. I'm not sure. Maybe you guys can correct me. Yeah, all these are TCAs except this. Should we discuss about the antidepressants or maybe depression? Amitriptyline is a TCA. So you're saying atomoxetine is a SNRI? Yes, it is an SNRI. But protilene is a TCA and amitriptyline is also a TCA. So all these three are TCAs. Yes, yes.
That's correct.
Yeah, please. Yes, Nightwing. Is it Nightwing?
I'm saying that you're right. All these
Oh,
the ones that ending with a suffix lean. They are
yeah, TCAs. Yeah.
we only have
Should
one
we?
SNRI. It's atomoxetine.
Yeah. Yeah. Think we can talk about depression. Okay. How would you define depression, or what are the characteristics of depression?
Excuse,
Yeah.
this question 81, is it me? I'm not understanding.
I think someone's asking something. Go on.
Now, the question 81, I thought it is saying all the following are selective norepinephrine reuptake inhibitors except. So we are looking for an answer which is not an SNRI.
Yeah.
That is my
So that
understanding. So atomoxetine, I thought is an SNRI.
But we will have three answers for this, yeah? That this is three answers to this. Maybe it meant only. Or maybe I know that these other three are TCAs, so except would be three answers.
Or maybe the question is the one that was not framed well.
Yeah.
mm,
Yeah, we can just answer like this. Should we talk about depression?
yeah, we should.
Yes, yes. Can you please take us through if you don't mind?
Don't remember much, but I think according to there was a certain criteria. But yeah, there has to be it has to be sustained for like a 2 weeks period, and during this time there should be at least a symptom like either there's diminished interest, depressive mood, sleep disturbances, weight loss, um, recurrent thoughts of suicidal ideation, yeah, and generally loss of energy. I think that was a criteria for depression. Has to be at least to have occurred within a 2 week period. So, which means if it's less than 2, then it doesn't qualify to be referred to as depression. and it also has to have either one of either the depressive mood, decreased energy, or a decreased mood in maybe the things that you find um, enjoyable, and the sleep disturbances and loss of energy. Yeah.
Could you also talk about the pathophysiology?
The therapy.
The pathophysiology, like those hypotheses, that it can be either caused by decreased brain levels of norepinephrine, serotonin, or dopamine. Then the other hypothesis was the serotonin and norepinephrine hypothesis that said that both of them are involved in antidepressants and postsynaptic changes in the receptor sensitivity. So that means there was this desensitization or downregulation of norepinephrine and serotonin that could lead to the onset of antidepressant effects.
Go on, Shvina. You're just explaining. Don't worry. Remember them.
Yeah. Yeah, that's all I have. What could be the causes? Or what are the causes?
I think it's mainly not known if there's an exact cause for depression, but there are the factors that might trigger depression, like maybe some genetics. If, for example, you have in your family, you have a first degree relative who might have had depression, there is a greater occurrence or likelihood for you of having the same. And also, it's also common with substance use or abuse. Um, then other major life stressors, like for example, if you've gone through a major, you'd say a life-changing experience, say like the loss of a loved one, or even the chronic uh, diagnosis of a chronic illness. Yeah. So things like would say physical trauma or abuse. Yeah.
Yeah.
We have others to add.
So can we say that depression can hit again? It's not totally curable. Like
But there are also other like drugs, pharmacological agents that have been implicated in depression, like the blockers, the resapine that we just think it was in our previous discussion, and also steroids and the substance abuse as well.
Thank you. What else is there? Dr. Sam, you can take us through the treatment. Yeah, we can hear you. Go on. Or anyone can take us through the treatment or the different classes.
Okay, maybe if I talk about the MAO inhibitors. The MAO inhibitors, there are two classes, the ones that block both MAO A and MAO B, and there is selective MAO A inhibitors. Then unselective include phenylizine and isocarboxide. For selective, we can remember the moclobemide. And the way they work is that they inhibit the metabolism of norepinephrine and serotonin. So they will what is it called? They will improve the norepinephrine and serotonin to improve the depressive order. Yeah. And one side effect to remember with them is that you should not, or side drug effect is that you should not take this with MAO containing foods like cheese, sausage, meat, because they can cause they inhibit the degradation of tyramine, which will cause increase in blood pressure and can lead to a stroke or myocardial infarction.
Just to add on that, so in that we have selective and non-selective. For the selective MAO A inhibitors, you have moclobemide and toloxetine, and non-selective you'll have phenylazine and isocarboxazide. Yes, go on. Can somebody talk about on the TCAs?
Okay, for the TCAs, they contain a three-ring membrane, three-ring nucleus. That's their name, tricyclic antidepressants. So they include amitriptyline, nortriptyline, amoxapine, and all that. So the mechanism of action is that they inhibit the reuptake of serotonin and norepinephrine. So they have what is it called? The neurotransmitter will be more available in the synapse to improve the mood effect. And also they block other receptors such as the histamine, muscarinic, and alpha-adrenergic. So they cause anticholinergic side effects, sedation, orthostatic hypotension. For SNRAs, that's the non-tricyclic, include duloxetine, venlafaxine, and desvenlafaxine. They're used for depression that's accompanied with symptoms of pain. And they're usually they're used as second line agents to those who don't respond to the SSRIs.
So let me ask, which is the first line?
SSRIs.
SSRIs are the first line. Second line is TCAs.
Yeah.
Okay.
And also just to add on the amitriptyline, all these TCAs are usually used for migraines and neuropathic pain.
SNRIs, yeah. Could you also talk about the SSRIs as the first line?
Yeah, the SSRIs are the selective serotonin reuptake inhibitors, so they just target serotonin. And so that's the mechanism of action. And they're usually the first class agents.
So they're also used for anxiety disorders or panic and OCD.
Oh yeah, and for also bulimia, eating disorder. And since they don't affect other receptors as we had seen in SNRIs, so these ones don't cause anticholinergic side effects.
Are these drugs suddenly stopped, or do you taper them down, or how do you go about it? And are they safe in pregnancy?
I think they are in category C or D, but you shouldn't abruptly discontinue SNRIs. It says it can cause nausea, dizziness, tremor, anxiety, and all that. Should be slowly tapered when discontinued to prevent this syndrome. The syndrome they're talking about is the serotonin syndrome, which can exacerbate when it's combined with other serotonergic agents.
Maybe then somebody can take us through the atypical antidepressants like mirtazapine, you have bupropion, and trazodone. Okay, the action of mirtazapine is just that it antagonizes the alpha adrenergic and serotonin receptors. That will mean that there will be an increase in norepinephrine and serotonin. Okay, if since we're talking about it, we can also talk about the bipolar disorder drugs that you have mood stabilizers such as lithium carbonate. And also to remember that lithium is a narrow therapeutic, it has a narrow therapeutic index. Okay, we can move on. One of the following is a disease. Wait, does anybody want to add on anything?
Yeah, I think just to add, for treatment, when you're treating depression in childhood, maybe say I think it's under 18, most of these SSRIs, they have a tendency to worsen the situation or predispose them to suicidal ideation. And the only ones that have been approved for depression is fluoxetine, and I think what was that one?
Thank you.
Okay, also you shouldn't combine SSRIs and MAO inhibitors because they will cause increase the
Serotonin.
tendency of serotonin syndrome.
Oh, the other drug is escitalopram.
Acetylop. Okay. We can go to the next question. One of the following is a disease-modifying antirheumatic drugs, the DMARDs: valdecoxib, methotrexate, misoprostol, and nimesulide. Methotrexate. I don't know. I think methotrexate.
Yeah, methotrexate.
Okay, we're talking about since we're talking about DMARD, we can just do a quick overview of the rheumatic disease, and then just a brief one. Somebody can tell us. Dr. Fatma Shafi, can you please, if you're okay, talk about the rheumatoid arthritis?
Okay, for rheumatoid arthritis, it's a complex systemic inflammatory condition that manifests in the tendons of the joints of the hands and feet. It's symmetric. It leads to joint destruction, disability, and premature death. Pathophysiology is it occurs when the immune system attacks the synovium. That's the lining membrane that surrounds the joints. And it results in inflammation, thickening of the synovium, which eventually destroys the cartilage and the bone within the joint. So it's different from osteoarthritis because this one is systemic. It involves the cardiovascular system, like the whole system. It's not only in the joints alone. For the diagnosis, you can use positive rheumatoid factor, and then elevated ESR, and then the C-reactive protein. There's also an antibody protein, I don't remember. There's an antibody protein that you can do, and then the synovial fluid analysis. Some of the treatment is the DMRDs that we said right now. It's actually the first line therapy for the patients with early onset of symptoms, like less than 6 months duration of the disease. We give methotrexate either as a monotherapy or combination with 2 or more of the disease-modified rheumatic drugs. You can just do one or you combine them. You can use NSAIDs for pain management. Low-density glucocorticoids are used to reduce the inflammation through inhibition of cytokines. By the way, when I forgot to mention that some of the pathogenesis, the rheumatoid arthritis is driven by T lymphocytes, so it causes response through generation of inflammatories. It releases some inflammatory factors like cytokines. So the glucocorticoids will inhibit the cytokines and other inflammatory mediators. So as I said, the disease modified is the first line of therapy. Yeah. Also, you can use biologic responsive modifiers that are indicated in patients who have failed with the first line therapy. It should be avoided in patients who have serious infection and demyelinated disorders like multiple sclerosis or heart failure. I don't know the reason they should avoid that. Some of the agents are tumor necrosis factor antagonist, like the adalimumab, and then interleukin-1 receptor antagonist, and then co-stimulation modulators, and yeah. And then in pregnancy, rheumatoid arthritis in pregnancy, as you know, methotrexate is category X, so you don't give it. So one of the safest agent for pregnancy is rituximab. Also, sulfasalazine is the drug of choice for pregnant or planning women who are planning pregnant. Rituximab is given to should be discontinued when they apply. Okay, you should give them before for them planning pregnant, and then you discontinue 1 year prior to plan pregnancy. So I think the safest is, I'm sorry, it's not rituximab, it's sulfasalazine is the drug of choice in women who are pregnant with rheumatoid arthritis. Yeah, that's what I can say.
Thank you so much. Thank you. Anybody wants to add on anything? That was a great summary. Thank you so much. Anyone want to add on anything? Okay. Next question. Spectral radiation with a frequency in the range of 10 to the power 12 to this hertz and a wavelength in the region of 300 micrometers to 3 micrometers is categorized as near infrared, far infrared, classical infrared, or microwave radiation. I don't know if it's near or far infrared, but it's infrared. But I can't say which one.
Why are we quiet? What's going on?
We are thinking of the question, answer to 83.
Oh.
I don't know if it's far infrared. What do you guys think the answer is? Near infrared.
Yeah.
The path length of a sample cell or a sample holder, commonly used in ultraviolet UV visible spectroscopy, is 1 centimeter, 2 centimeters, 5 or 10. 1. Yeah.
Yeah, it's 1.
Tablet hardness is usually expressed in terms of kilogram per centimeter squared, kilogram per centimeter cube, kilogram per centimeter, or newtons.
Kilogram per centimeter.
Not newtons.
Kilograms per centimeter cubed.
Mm-hmm.
Is it cubed or just centimeter? I thought it's just centimeter.
Okay,
It's
I remember it's cubed.
cubed, or it's
Next.
something with newtons also.
Excuse me, could you please go back to question 83? I'd like to screenshot it kindly.
No problem, no problem. Yes, yes.
Okay, thanks.
You okay?
Yes.
So we go with B here, yeah? Which one of the following detectors is not commonly used in
It's not
HPLC? Yes, yes, Nightwing.
I'm thinking it's
You think it is A?
It's
B.
A.
It's A.
It's kilogram per centimeter squared or cubed.
It's per centimeter square.
Trina, I think it's squared.
Hardness is in squared. Okay. But it can also be newtons, yeah?
Newtons is actually what you get in the machine, the hardness machine. But when you express it in terms of kg per centimeter.
Oh, okay. Sawa. Which one of the following detectors is not commonly used in HPLC chromatography? Spectrophotometric, conductimetric, electron capture, photomultiplier tubes.
Photomultiplier tubes. I've never had that in HPLC.
Mhm. Everyone says D. Anybody with a different answer?
ChatGPT says for question 55 it's newtons or kilopascal.
It says
Newtons or kilopascal.
yeah. I thought it's newtons.
Fatma, where did you get that it's kg per
I was using based on the knowledge that I was doing in my project because I was expressing it with kilograms per centimeter squared. So I don't know if that's what I was using for my project. I don't have any reference in short.
Wait, my reference is just Weather's notes. He, at one point, he did, when we were doing those tablet tests. Was
Okay,
there.
according to his, yeah,
Yeah.
he's showing the limit, yeah. So in limits, if it's an oral tablet, is 4 to 10 kgs. If it's a chewable tablet, then it's 3 kgs. And if it's a sustained release tablet, it's 10 to 20 kgs. Then when it's doing the calculation, it is just newtons. It's used newtons. I would go.
Okay. It's okay.
Okay.
We can go with newtons.
Sawa. Which one of the following detectors is not commonly used in HPLC chromatography? Is photomultiplier tube used in HPLC chromatography?
Yeah, they're actually used. It's saying here they are highly sensitive detectors used in HPLC. They used to detect the ability of weak signals, making them suitable for application where the compounds are interested and representing low concentrations. And then some of the detectors I see here is UV detector, fluorescence detector, refractive index detector, electrochemical detector, mass spectrometry, evaporative light scattering detector. So there's spectral. I think photon multiplier is also there.
What about conductimetric?
I'll put conductimetric. That one is not. Yeah, I don't see it here.
You can share the picture they're using.
It's ChatGPT.
Copy the answer. Put it. Well, you can't rely on ChatGPT, man. At times it's true, but okay,
Even
just share what you have on the group. Copy that answer. Somebody is saying C. Why do you think it's electron capture? Do you think it's because of the, I don't know.
even conductimetric it's in HPLC. It's used in HPLC also. It's a detector technique that measures changes in electrical conductivity at the element as analytes passes through the detector cells.
I think even C, because I feel electron capture is used mainly for gas chromatography. I'm not sure, but I don't know if it's used in HPLC. Have you asked ChatGPT?
So the chat GPT is saying for the electron capture detector, while it's using GC, it is not a common detector for HPLC.
Yeah.
Mm.
Yeah, it's saying that.
So we go with 86C. The recommended temperature for the preparation, standardization, and usage of all polymetric solution is 25 degrees, 20 degrees, 30 degrees, 50 degrees. I would go with 25. Everything at 25 degrees Celsius or 35. I don't know.
Yes, though that if I should.
But if it was something to do with microorganisms, we would do it at 35 degrees, yeah. So maybe 25 degrees. What do you guys think? But I think 25 degrees is optimal. I don't know. You guys tell me if it is right or wrong. I would also say 25. Yes. I think that's not something to really discuss about, unless somebody has a point.
ChatGPT, it's saying for the preparation of the temperature for the preparation, standardization, and usage of polymetric solution is usually room temperature, which is around 20 to 25. That's 68 to 77 the degrees per F. Celsius per F, I don't know. Yeah, Fahrenheit.
I don't know.
Yeah.
So, according to your ChatGPT, would you take A or B?
It said 20 to 25. So I'll take A.
Okay.
But as you
Very-
wish. You can even take 20 if you wish.
No, you would rather go for 25.
Yeah, 25 is on the safer side.
Should we move on to the next question?
Yeah.
The linearity of the scale of a polarimeter is checked by means of which solution? Glycerin, gelatin, glucose, sucrose. Sucrose solution. We have 20 minutes. Maybe we can do a lot in those 20 minutes. We can do next 10 questions. We can finish. Maybe. Maybe. What do you guys think? Is it sucrose?
We can finish if everyone is contributing and talking. We finish it haraka. But no one
It's
is
not
even.
just about finishing, but we can also add on to points. But this last questions, I have nothing to talk about. I'm very blank.
Me too, I'm blank. I don't even know. This one, this 89, I don't even know the answer.
Oh, we're talking about 88 right now.
Or 88, I mean. It's sucrose solution.
According to Google. But I don't know what the others have. Just as you're checking out the answer, polarimetry is a sensitive, non-destructive technique for measuring the optical activity that's exhibited by inorganic and organic compounds. Oh yes, yes. Okay. So it is sucrose solution. It can. I'm going to the next question. The apparatus used for the determination of the weight per milliliter of a liquid is known as a pyranometer, calorimeter, polarimeter, or a hydrometer. Hydrometer, because it's dealing with liquids.
Someone said A, another one said D.
D is correct for sucrose,
No, this one for 89.
or D is correct for A. D or A?
The one for D, it's used to measure the density and specific gravity of liquids. I would go with hygrometer.
My weight per milliliter.
Weight per milliliter is its density. Then I think A is right, because A, it's saying it's used to measure the density and specific gravity of liquids.
Sorry, I was wrong.
So if picnometer measures for the density, then the hydrometer, what does it measure?
Hydrometer measures the relative density of liquids. It's saying here the hygrometer works in principle of buoyancy, where the degree to which the hygrometer sinks or floats in liquid indicates the liquid's density relative to the density of water.
It's showing that it doesn't have units. The scale doesn't have units. Because it's just comparing the mass of a liquid to the mass of a pure water.
Yeah, hygrometer. We go to the next question, or someone has something else to explain of that.
I was seeing what the polarimeter, the units. It measures the optical rotation. But what are the measurement units?
I think the question is asking for a way of measuring the density of the liquid, because it's saying that it's weight per milliliter, which can easily be translated as density.
Yeah,
because we can represent density as grams per ml.
Yeah, weight per milliliter is density, but what we're asking is hygrometer. It doesn't specify the weight, the
Well, ChatGPT says it's a hygrometer.
Okay.
So should I just put this as a red? Okay. The most popular chromatographic method used in the analysis of pharmaceutical is paper chromatography, thin layer chromatography, gas chromatography, or liquid chromatography. I think we did this and we said liquid chromatography because that's what almost all industries have, HPLC, right? Amma?
Someone said here, hygrometer device for measuring some characteristics of liquid, such as its density, specific gravity, weight per unit volume compared with water. That's what I was saying. The more appropriate answer is A than hygrometer. But unaweza jibamba uweke any. It's okay.
Number 90.
Number 91.
90.
Hmm?
Number 90.
I'll go with liquid chromatography too. Unless someone has different answer.
All the following instrumental techniques are commonly used for structural elucidation of chemical molecules except infrared mass spectrometry, spectropolarimetry, and NMR. Did we go with spectropolarimetry? I think we had done this question somewhere.
NMR.
And no, we
NMR
said
must NMR must spectroscopy infra red. They're all used in elucidation of structural chemicals. I think the answer is C.
yeah, because spectropolarimetry is just analyzes the fluorescence from a molecule based on its fluorescent properties. Yes, I
Yeah.
think we did this. Which of the following drug is not a metabolite of streptomycin? Erythromycin, tetracycline, chloramphenicol, or penicillin G? Maybe, I don't know. Penicillin? Say the streptomycetes can give erythromycin. They can also give chloramphenicol and tetracycline.
Yeah, I think it's penicillin G.
Also to add on, they can give vancomycin, rifampin,
And then nystatin.
and cephalosporins. They can give cephalosporins but not penicillins. Yes, Dr. Shafi, you were telling us something.
Also, antifungal agent nystatin, you can give it.
Which one of the following is a beta-lactam antibiotic? Meropenem, clindamycin, tiocoplane, or cincoxacin?
Meropenem.
Yeah. What's the class for the last two? Clindamycin is a lindo something. What's the class for tiocoplanin?
Let me check.
It's a glycopeptide antibiotic.
Lipoglycopeptide.
Yeah.
It's used to treat methicillin resistant stuff, aureus.
And the last one is a quinolone, used to treat UTIs. Anybody wants to add on something about any of this drug? We looked at the classes: meropenem, beta-lactam is clindamycin, the lincos, what is it? Cincoxazine is quinolones, and teicoplanin is a glycopeptide. Anything else? Which one of the following statement about anti-cancer agent is true? Methotrexate is a pyrimidine antimetabolite. Daunorubicin is an anthracycline antibiotic that is hygroscopic and sensitive to light. Melphalan is a nitrogen mustard, but is a prodrug converted to the active form phosphoramidate mustard by liver CYP450. Etoposide is a semi-synthetic drug product of vinca alkaloid used in small cell carcinoma.
First, etoposide is out because etoposide is topoisomerase 2 inhibitor.
Yeah, I think the answer is B.
And then
Daunorubicin
methotrexate is, yeah, the
anthracycline.
answer is D, is B.
Yeah.
Melphalan is alkylating agent, and then methotrexate is purine, I think, anti-metabolite, not pyrimidine.
Mm. Okay. Going to the next question. All the following statements about non-antibiotic antimicrobials biocides are true except bicarbonate are cationic, interact with phospholipids disrupting the membranes. The quaternary Emma, we continue from here tomorrow. What do you guys suggest?
Yeah, then we can continue.
Tomorrow.
Thank you, everyone. Thank you.